Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in this latest video. This is of a very interesting case of a patient who was referred to me by a colleague based in the east of England. And this patient visited my colleague reporting excruciating otalgia. So otalgia is a medical name for earache in this their right ear. And as soon as my colleague entered the ear and made contact with the surface of this, what appears to be at the moment a plug of earwax, they immediately realised that this is going to be really painful for the patient and recommended that the patient visit myself. So the patient travelled earlier on last week, and when we're doing our triage over the phone during the booking of the appointment, as soon as the patient notified us that they are experiencing really severe otalgia, immediately in my mind I thought this patient's got keratosis obturans. So keratosis obturans differs to earwax, and I've had a lot of keratosis obturans cases recently in the last couple of weeks. So if you want to watch some more, and they are all very interesting cases, keratosis obturans, if you visit my YouTube channel, so if you're watching this on a different social media platform, just go over to YouTube. You can search the Wax Whisperer, or my name, Neel Raithatha, or the Hair Clinic, and you should come up with my YouTube channel, and from there you can go to playlist and select keratosis obturans. So upon attending, the patient was quite anxious because they were obviously under quite severe duress with all this pain. They had travelled a long way as well, and they were really hoping that I could remove this for them. And I kind of felt that they were under so much pain that this is almost like a last hope for them. They were referred to the hospital to see ENT, but that was months away. And in some cases, ENT are probably slightly better equipped to remove keratosis obturans, and that's because they can introduce some topical anaesthesia, which as an audiologist in the UK we're not allowed to see. I had to do this without any form of anaesthesia, and the patient, of course, as I mentioned, they were already in pain upon attending, so I did counsel them to advise that if they're already in pain, me entering the ear is unfortunately going to add some additional pain until I remove this. I always feel it's best to be honest with the patient, and I think the patient was grateful for that. They had their husbands sit next to them, and they were holding their hands really, really tight, and there were a couple of occasions where the patient did shout out some expletives, but it was fine because no one was in the waiting room at the time. And that's what keratosis obturans can do. It can be so painful. So one of the hallmarks, well, in fact, if you suffer from keratosis obturans, the one symptom that you must exhibit is ear pain. Now, it doesn't mean that if you've got ear pain, then you've automatically got keratosis obturans, but it does mean if you've got keratosis obturans, you must exhibit ear pain. So that's a symptom under all grades of keratosis obturans. So grade 1 is the mildest, grade 4 is the most severe. With grade 1, it's mild pain in the ear and obviously a build-up of this dead skin, which I'll describe a bit more in a moment, so you'll understand what, for anyone new to the channel, I'll discuss what keratosis obturans is and how it differs from earwax. So keratosis obturans also can develop a widening of the ear canal, but in a grade 1 there's very minimal widening of the ear canal, and if there is, it's not really noticeable. A grade 2, there's some mild expansion, widening of the ear canal. A grade 3 is moderate expansion, and a grade 4, the expansion of the ear canal is so severe that the ear canal merges with the bone at the back of the ear, the mastoid bone, so that's extreme. I've only probably seen one of those in my career, and they are normally performed under generally they need to be referred to see ENT and have surgery performed. And a grade 3 differs from a grade 2 in that there's the presence of granulation tissue at the juncture of the bony and cartilaginous portion of the ear canal, so about a third of the way in. and a grade 4 is the severe bleeding. So you can see the scales there. I'll classify this as a grade 2. So what is keratosis obturans and why is it painful? Now, keratosis obturans on first appearance looks like earwax. You can look at that and you think, well, that's earwax. But as soon as you make contact with this plug, I knew immediately that this is not earwax but dead skin. So dead skin plugs can form into keratosis obturans. So keratosis obturans is purely sheets of keratinized dead skin, whereas earwax contains dead skin, but it also contains oils and lipids and oily sweats. So earwax typically is 60% dead skin cells, and the remaining 40% is oils, lipids, and as I mentioned, sweats, and they all amalgamate to form earwax. But keratosis obturans is dead skin, and the dead skin in keratosis obturans, they are typically in sheets. So the ear canal and the outermost membrane of the eardrum is made up of a layer of skin. And that skin, as it dies, it should shed and migrate sideways out of the ear. And as it dies and sheds, the skin cells, which are previously connected to one another on the surface of the skin, the epidermis layer, they begin to detach themselves from one another. So the skin cells, instead of being a sheet of skin cells, they become individual dead skin cells. They lose their attachment to one another. And this skin slowly migrates out of the ear in a conveyor belt motion at the rate of about 1 millimeter to, well, 1.5 millimeter to 3 millimeters a month, so equivalent to the growth of our fingernail. So this, and that skin that dies is replaced by another layer of skin, and then eventually that skin will die, it will shed, and it will migrate similarly to the previous layer of skin. So it's a continuous cycle of our ears producing skin that lines the ear canal surface. That skin dies, it's replaced by another layer of skin, and that dead skin then slowly makes its way out to the ear. And if the ear wasn't able to do that, then all of our ears would be full of dead skin and we wouldn't be able to hear. So the ear has evolved to self-cleanse itself of dead skin. If you have dead skin on any other part of the body, then when you're showering, bathing, or putting your clothes on, or giving a little scratch, the skin cells naturally exfoliate themselves and they fall to the ground, to the floor, and swept or vacuumed up, or they enter the atmosphere. But we don't have that luxury in the ear, and that's why the ear has evolved itself to cleanse itself of the dead skin. And as the skin naturally comes out of the ear, any wax sitting on the surface is also naturally exported out of the ear, so it also helps to remove earwax. And this skin starts to migrate and shed from the centre of the eardrum. So the centre of the eardrum, where the hammer bone, also known as the malleus, where it attaches, is called the umbo. So you'll see it a bit later on in the video, but that part of the eardrum is called the umbo. And what some scientists and ENT surgeons did a few years ago, they did this ink study where they blotted some ink around the eardrum near the centre, and they got the patient back on regular appointments to see how these ink blots, their positioning and the distance away from the eardrum at certain time periods. And they found over time these little ink blobs, blots that were made on the eardrum, that they migrated radially. So when I mean radially, imagine you've got a puddle of water or a pond of water, and you drop a pebble, stone, right in the centre, you'll get those ripples from the centre, from the epicenter. Or you know, think about a natural disaster and you've got an earthquake and you've got the epicenter, and then you've got the shock waves that ripple from the centre outwards. If you have that image, that's similar to how the skin sheds from the centre of the eardrum. It ripples outwards all the way around in a ripple effect. So the ink blot that was originally on the eardrum in the centre, it would migrate sideways off the eardrum and then out of the ear canal and slowly out of the ear. Now, keratosis obturans is when this skin migration, for some reason, is either it's altered, either the skin no longer migrates, or it does migrate but not quick enough. And also, the sheets of dead skin, they don't disconnect from one another. So as I said, normally the individual skin cells begin to detach from one another as it dies from the surface of the ear canal. But in cases of Keratosis obturans, quite often these individual skin cells don't separate. They remain connected, and it's still in sheets. And these sheets of dead skin then form and coil over each other and wrap over one another, and that leads to Keratosis obturans. And the skin plug then begins to grow. It forms into a plug. And the best description I can give for Keratosis obturans is it feels like a rubber ball. And this rubber ball has got so much kinetic energy, because you can imagine all those sheets of dead skin that are folded upon each other. It's got so much force and energy that it begins to physically widen the ear canal. Now, the bone that surrounds the ear canal, the temporal bone, is regarded as the second most strongest bone in the body behind the femur bone. So you can imagine how much force this plug of dead skin, as we know, and what we call Keratosis obturans, must have in order to physically begin to alter and widen the shape of the ear canal. Now, in cases of Keratosis obturans, the skin that the latest layer of skin that lines the ear canal, so the active skin, the skin that's alive, it's not, or it's typically not affected. It's still there. It's not ulcerated in any way. And that's where canal cholesteatoma differs. And it's too much to probably talk about, but canal cholesteatoma is a very rare condition whereby the dead skin, it's almost like a Keratosis obturans, but it can form a plug, and it's normally in the posterior inferior section of the ear canal, so the bottom back section, where it's known where that region of the ear canal is where the skin doesn't migrate as quick. And so you get a buildup of dead skin there, and this skin releases lysosomal enzymes and acids, which then ulcerate the skin, and the bone becomes exposed, and then the bone beneath the skin, which is no longer there as it's ulcerated, becomes sequestrated, so it separates from the rest of the bone because it's devascularized. The blood supply to that section of the bone has been halted because of the infection, so that bone dies. So it's undergoing necrosis, so decaying, and then you get pieces of bone, so sequestrated bone. So a canal cholesteatoma is typically more localized to a specific point in the ear canal. The skin is breached, ulcerated, and there's evidence of discharge. With the Keratosis obturans, it's more uniform. This plug is all the way around the ear canal. It's not localized to a specific point on the ear canal surface. And there's not always discharge or active infection with Keratosis obturans. You can get some granulation tissue there, as I mentioned, on the grade 3 and grade 4 onwards. So that's the difference between a Keratosis obturans and a canal cholesteatoma. And also between earwax. Now, so the medial canal here is widened, and there is a bit of swelling in front of it. And I know I haven't talked much about the procedure, but I'm just using various instruments. I'm using the metal instruments. I'm using forceps here, and I managed to get that out, and I was really pleased, but there's still quite a bit in there. But you might have seen that I was using a Cawthorne hook. Now, a Cawthorne hook, it's not something I often use. It's really, really a sharp end. And of course, with metal stainless steel objects in the ear, they are a lot more rigid and stronger than the typical polycarbonate or carbon fibre instruments. And when you've got a sharpened tip and the patient's awake, there is obviously, of course, more chance of doing trauma. So I only really use them as and when necessary, and it's not often I need to use the metal instruments. You can get kind of thinner plastic instruments like a rose inserter. Now, a rose inserter by nature was designed to insert stuff into the ear, like a grommet into the eardrum, but they can be quite effective to remove earwax in certain instances. But they are, because it's not made out of metal, they can, and I've had it done once and I've not used it really since, that the end almost snapped off, and I got really, really worried because we don't want that flying off in the ear. And they do flex a lot in the opposite direction. So in a plug like this, which is really, really strong, it's not really going to be effective, but I can see its potential. And I know other specialists use it to good effect in different cases. So, but when I'm using the really sharp instruments, again, the plastic ones sometimes are more effective because if they do touch the ear canal wall, they're less likely to cause trauma, but sometimes we do need brute force, and so you just got to use the metal ones. So it's not something, I do train specialists to use the metal ones in the mannequins, but it's seldom that I need to use them myself. But you can see how, well, you probably can't see because it's embedded into the wax, but it's such a sharp instrument, and that's got the potential to pierce the eardrum. So we're almost through the swelling, we're just mopping up here. So for my colleague who referred, I think they did the right thing. This is one of these cases that it's not straightforward, and I've done loads of cases of Obturans. It's something that I am seeing more and more of, getting more referrals from the specialists and colleagues asking me to perform it, which I'm more than happy to do, but they are really, really challenging cases because of the pain. If the patient was asleep or they had some sort of anesthesia, then we can almost kind of, we can go at it a bit more, but I've got to bear in mind the patient's awake. Now, it's difficult to visualize the eardrum, but it is there. There's this bit of dead skin on the side. You can just see how sore and inflamed the ear canal is there. It's really tender, and beyond that, the ear canal, it is also inflamed, but it's widened. So I would say this is a grade 2. There's no granulation tissue, so I wouldn't call it a grade 3. Now, in a moment, you're going to see me halt the procedure here. And what happened was I was using a fine end to perform microsuction, so that's the smaller vacuum. And although I didn't make any contact with the ear canal wall, the patient suddenly experienced a sudden shooting acute pain that was not only in the ear, but also travelled down the side of the neck. So I showed the video back to the patient. I wanted to obviously show them that we didn't make contact, and they felt their ear to become blocked after that. And what I suspect happened, well, I'm pretty sure it happened because I managed to resolve it, was as I was performing suction, the eardrum is now exposed. And sometimes, it's very rare, but when you perform microsuction, it does pull, although you don't make contact with the eardrum, but it does pull the eardrum laterally, so towards the entrance. And that can alter the middle ear pressure. So it can actually reduce the middle ear pressure. So by flexing the eardrum laterally towards the entrance, the volume of the middle ear, so the cavity behind the eardrum in the middle ear, is increased because the eardrum's flexed towards me. So it creates more space behind the eardrum, and then that lowers the air pressure behind the eardrum. So you actually get negative air pressure, and that can cause a fullness sensation, and it can cause a bit of pain, otalgia. And what I did, I re-equalized the pressure by performing a pressure test that audiologists have access to, called tympanometry. So tympanometry is a pressure test designed to do many things. Actually, it's designed to essentially at heart measure how well your eardrum and the 3 bones, so the middle ear system, is operating. And yeah, it assesses that in different ways. It assesses the optimal pressure in the ear canal, whereby your eardrum is most compliant. So the eardrum is most mobile and compliant when the air pressure is equal in the atmosphere, so before the eardrum and behind the eardrum, so in the middle ear. So what the tympanometer test does, it sweeps different air pressures in the ear, and it, whilst playing a low frequency sound, and it can calculate how much sound is absorbed by the eardrum, if you like, and at what pressure. And at the pressure whereby the most sound is absorbed by the eardrum is, so that was the point I think I mentioned earlier, where the patient felt this sudden acute pain. And so I'm just looking to make sure there's no trauma there, which there wasn't. So yeah, the point at which the ear canal is most mobile, so absorbing most sound, is the optimal air pressure. Now, I went back in again and it happened once more, and you'll see that, where the patient just felt this sudden pain. So we just left it as that. The patient could hear, they need some antibiotics, steroids just to reduce the inflammation, but they were so happy. I do not want to, sometimes you don't fix what, something that's not broke. We've got to the stage where the patient's really happy. Yes, the ear is really, really inflamed and angry, but they can hear again. So yeah, we can determine the optimal pressure. We can determine the pressure behind the eardrum by measuring how well, at what pressure point the patient is absorbing most sound. The tympanometer test also assesses the ear canal volume to see how big the ear canal is. So it's a very useful test, and by sweeping pressure, we managed to equalise the pressure in that right ear. That's all the debris from the patient's right ear, or the Keratosis obturans. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.